Thanks for joining. Today I'm going to be interviewing a friend of mine from medical school. Aside from being a close friend, she is also someone who has had a tremendous impact on global health, which I think is really inspiring. It certainly has been inspiring to me, and I think will really have a far reaching impact to listeners of this program. Her name is Dr. Pavani Ram, and I'm going to just list off a few of her accomplishments. She has directed and led a sizable team managing $500 million of USAID, the USAID portfolio. She's represented the US government in Gavi, which is a global immunization initiative. She has been very involved in newborn and child health. She has published over 100 peer reviewed papers. She has over 7,000 citations. She was a tenured professor at the University of Buffalo, and she left that position to lead a very important initiative at USAID. And I'll let the interview play out so you can see a little bit about how she got there and then what happened. She also has a very successful coaching business where she provides coaching expertise to pretty high functioning people, executives in medicine, in business, and in public health. I really am honored to know her, and I'm glad she took a little time out of her very busy schedule to give some time to this program. I'm excited for you to listen to what she's been able to accomplish, and I'm really proud of her. So thanks for listening, and let's get started. How are you?
Hi, Elka. Great to see you.
It's great to see you. Pavni and I went to medical school together at Mount Sinai. She is a close friend, but has been a real role model for me. I just wanted to let you know in this forum that really you were one of the hardest working people I've ever met. I mean, so hardworking, so honest, and you did everything you did with a lot of integrity, which I really admired. So I ended up staying in New York and doing general surgery at Mount Sinai. You ended up leaving New York after being there for a long time because you went to
Yeah.
Columbia and going to WashU to do internal medicine. And obviously this is a top rate program in internal medicine. And then you took a shift, and I'd love to hear about that shift and why you made the choice that you did. Because what I remember is when you told me that you were going to be doing what you were doing, and I was surprised because I always sort of imagined you kind of doing one-on-one with patients, but that's like not at all what you ended up doing. And
Yes.
so I actually think it's important for people to understand that these options exist and that you don't necessarily have to do the one-on-one with patients if you have other goals. So that's why I thought it would be such a great opportunity to be able to hear a little bit about your trajectory.
Thanks, Elka. It's just such a pleasure to be here and to share this with you. It's been quite a journey since we were in medical school together. I really loved our time at Mount Sinai, but it was also a hard time for me on a personal level. I had some health issues that had some long-term consequences, and it was a really difficult time. Um, and at the same time, I really was intellectually very stimulated. I got to say, especially in the clinical years of medical school. The first 2 years were rough all around, but the clinical years were great. And I found myself excited about a number of opportunities and certainly internal medicine. I was at Columbia for undergrad, and then I worked for a year in between college and medical school at the New York City Department of Health and Mental Hygiene, and then was at Sinai. I had done a short stint at the Department of Health during college and then before medical school. And that was such an opportunity for me to see public health in action. And I really carried that through with me pretty much for the rest of my career. I left Mount Sinai because I wanted to go to a different training institution. It was important to me to see that medicine, in many ways, was a culture. How one practices medicine is often a culture of that institution. And so I wanted to see how medicine is practiced and learn that practice of medicine at a different culture and a different institution. It was an important one that I take that leap. And also, I was the furthest I had lived from my family, and I was really looking to be more independent, grow some muscle in terms of that independence, and really start fresh in a way. And so it was an amazing opportunity to do that.
I remember times where I was trying to figure out how to just get through an operation, and you were in Afghanistan setting up water systems
Yeah.
there. How did that all sort of happen?
Yeah.
Finish your residency and then what?
I think back to the days I had done this 3-week summer program between my junior and senior years of high school in New Jersey. It was called the Governor's School for young people around the state of New Jersey who were interested in social issues. And to be honest, as I launched into college, I was thinking I would have a career in anything from law and psychology to anthropology and maybe international relations. But I never thought about medicine until about halfway through. I'd been really steeped in New York City, went to Columbia, which had this beautiful campus. And then right outside campus were all of those social determinants of health that we know very well.
Right.
And as I looked around, I had this privilege of being able to be steeped in like the literature and philosophy and asking all the big questions about life and wondering what made the difference between my ability to be there in the classroom asking these questions and somebody else's ability to be there who either lacked good health, housing, education, these sort of fundamentals of that allow us to grow to our fullest potential, right? And that is a matter of opportunity and not of intellect. And so it really struck home for me that I wanted to be doing something to alleviate that burden for others. So as I decided to go into medicine, I also then started to explore different aspects of medicine. Could I become a researcher? Could I become, what kind of clinician might I be? And so I worked in the emergency department and I worked in a lab, in a biology lab. I broke lots of glassware. I was done. It was not the path for me. So then I did an internship at the New York City Health Department. And at the health department, I was part of the Office of Child Health, and that was just when Child Health Plus was being launched. At the time, kids wouldn't get vaccinated, they wouldn't get primary care because their parents were either uninsured or underinsured.
Mhm.
And Child Health Plus was this landmark program that started right in the early 90s to support families who were uninsured or underinsured to have access for basic health services for pregnant women, new moms, and young children. And it seems so obvious now, but at the time it was really new. And so I ran around all over the city during my time, as well as later between college and medical school, supporting moms to sign up themselves and their children for this program.
Wow.
And whether it was in Brooklyn, which wasn't as
And
wealthy as it is now, right? I got to see a lot of New York City that wasn't experiencing the life I was experiencing at Columbia or that I would later experience over the course of my life. That really cemented for me that public health is an instrument of social justice. And I hold that value to this day.
Right.
That what we do for the masses in terms of ensuring good health is truly an instrument of social justice. And that drives me all
Wow.
through.
Just hearing that, it's inspiring. And for me, that sounds trite. It's more than just inspiring because it so absolutely exemplifies what I remember of you and being friends with you. And that's what I mean is that when I said I really try to emulate that, that came through in what you did in the school. And it really had an impact on me. What's interesting about vascular surgery is that social determinants of health play such a huge role in how our patients experience their care. Like it plays a huge role in why they even come to see us in the first place. Gaps in screening, poor diabetic control, poor hypertensive control. hypercoagulability in young women. And it just, there's all these smoking, for example. There's a lot of that we deal with on a day-to-day basis, but we're dealing with it in a lot of circumstances, one patient at a time. And you have kind of built a career of managing or at least trying to tackle some of these issues on a much broader scale. Do you ever, or did you ever miss the one-on-one interaction with patients, or were you able to kind of get that in different ways, like when you went to overseas and to other countries to set up health systems there?
Yeah, it's a good question. When I was in internal medicine residency, I applied to the CDC, to the Epidemic Intelligence Service, the EIS program. Within 2 months, I was dispatched to investigate the largest botulism outbreak up until that time in the decade in Texas. It was my 30th birthday, and I was like driving to Texas, to like landing in the airport, driving to the sort of scene where we were meeting with the state health department, and we were going to learn all about what was going on in Texas in this outbreak. It was a massive outbreak of botulism as far as botulism outbreaks go. But it was this incredibly compelling moment to think about where this is about the potential to save many lives, because a dozen people were on ventilators at the time in this outbreak. And we didn't know what the causative food was, and that many more people might have been exposed. So, like, the rush was on. That was a really powerful moment. While I was in Texas, 9/11 happened. And all of the incredible efforts that needed to be made from a public health standpoint to protect the public's health. And then soon after that was the anthrax attacks, right? Public health was critical for safeguarding the lives of millions of people in this country. And then obviously, as you mentioned, around the world.
Right.
So I had an opportunity during that first year of my EIS program to go to Afghanistan, which you had mentioned. It was months after the US had invaded, because we were, the US government was trying to uproot the Taliban and the Al Qaeda because of its connection to 9/11. But it was a moment where there was also this willingness and interest in the US government to support the country of Afghanistan to improve its health and water and other infrastructure. It was a deeply powerful moment for me and totally pivoted. What I thought when I had gone to CDC, I thought I would end up back in New York City or another big city public health program. And then I went to Afghanistan, and it completely pivoted me towards a global health career.
Wow.
I knew very little when I went to Afghanistan, like very little. It was all learning all the time.
Mhm.
And it has been like that for 25 years, all learning all the time. I have learned so much more than I have given.
Wow. So, what is happening with those water systems or the other health efforts now in Afghanistan?
Yeah. Afghanistan has had a deeply rocky time for many decades, if not centuries. And conflict has been a constant there. We worked on a type of water treatment program that was about household treatment, because water infrastructure is incredibly expensive, and it often doesn't reach communities that are further from urban areas, right? And so we were about supporting families to be treating their water at home in order to make it safer to drink for their children who are at highest risk of dying from preventable deaths from diarrheal disease.
Sure.
These projects have happened a lot in lots of countries around the world. And it really takes sustained effort, both to sustain the production and distribution of chlorine and to make it a marketable solution, because you want it to be self-sustaining, but also the behavior change that it takes to do that day after day. The evidence around household water treatment has evolved significantly. I have lots of colleagues who've worked on inline chlorination, meaning chlorine being filtered into the water as it's being collected. There are loads of ways to do this. And I think we're doing better and better now at thinking about how to advance communities towards safer water. So that was that early part of my career. I think you were also asking me this question about whether I miss patient care. And I had many colleagues who have continued public health and continued patient care at the same time, whether they did a half day a week or they would do several weeks out of a year of a rotation and things. To be honest, because of global health, I was traveling a lot. And then within a few years after that, I started to have a family and we had our children. And I really didn't feel like I could do both all of my global health and be a great parent and wife and daughter and all the things and friend that matter to me. And in that sense, I didn't want to do mediocre patient care. I really wanted to say, I'm going to make a choice here. I'm deeply passionate about global health. I want to keep doing that. Yes. Do I miss one on one interaction? Yes. Although, like my current chapter that I'm heading into feels a lot of one on one connection.
Yeah.
But a few years after I had joined the university at Buffalo and where I was doing public health research, I was driving in the car with my parents, and my mother was saying something along the lines of, "You miss having that one on one." And my father said to her, "No, it's not that she's not a physician. She's a physician for millions of people."
Oh, wow.
And I felt like whether I have actually had that kind of impact or not, it was actually really meaningful to me to have my parents understand that as my identity as a physician is very much with me, that is who I am.
Right.
And at the same time, the impact I'm seeking to have is at a population level.
I know of people who are in surgery and want to have that be an element of what they're doing. I do think it gets hard to do because very much like what you said is when you are going to be at the top of your craft, you have to be doing that. So like for surgery, for example, you have to do surgery in order to be able to continue to do it. And so I do agree that at some point you sort of have to make a choice, but I love that analogy or that visual of what your father said about being a physician for millions. And I'd say that
Mm.
is very accurate. It's a really impressive story. You were at the University of Buffalo working within a department. Is it an epidemiology department or public health?
Mhm.
Yes.
Environmental health and the School of Public Health.
Okay.
Yeah, and health purpose.
Got it. And you end up becoming in 2019 a senior medical advisor for child health and having an interaction with USAID. Can you tell me how that came about? And it seems like that you did that for about 5 years, something like that. Is that right? Or was it longer?
I had multiple roles at
Yep.
USAID. When I was at CDC, I had started to build up this network in global health. One thing for your listeners who may be earlier in their careers is the network never goes away. And so actually keeping that network warm, staying in touch with people is so important. And I'm the living example of that. A colleague, when I was quite early in my career, that I met at USAID back in 2002, um, when I was at the University of Buffalo, I was a co founder and co director of a community of excellence for global health equity at the university. Had an opportunity to invite a speaker in for a kind of presidential speaker series. And so I reached back out to this colleague at USAID and invited him to come and be the presidential speaker. It was a terrific talk. He came, spent a day and a half with us, and engaged a lot of our faculty. And so we spent a lot of time together engaging on the latest of the global health issues. We'd been seeing each other on and off at meetings and other things. And during one of those interactions, he said, "Why is it you don't work for me?" And I said, "Because I need to be in Buffalo. This is where I live and my family's here. I need to be here." He said, "We have ways around that now." And that was in 2016. And so he actually supported this opportunity for me to have an arrangement between the University of Buffalo and USAID, where I started to become a part-time, a senior medical advisor for newborn health. I'd been doing a lot of work on hand hygiene in the newborn period, and it was an opportunity to support infection prevention and control and other work that the newborn team was doing at USAID. From there, I landed a full-time position. I left my tenured position at the State University of New York at Buffalo and went to USAID as a contractor, as a senior medical advisor for child health. People often wondered because a tenured position in a state university like that is a job for life. But to be honest, I wanted a job that where I felt like I was making an impact on a regular basis. And um, as much as I continue to love my colleagues at the university, and deeply appreciate how much I learned during that time that I was there. Going to USAID, it was like slipping on shoes that were really comfortable. How like when shoes just fit, it felt like that.
Mhm.
Like all of a sudden, I was going to work in the supporting the work that was directly connected to women and children. And that was hugely important to me. And I was a senior medical advisor for child health for 2 years, and then I became the division chief for child health and immunization. In 2020, I was still a senior medical advisor for child health, and the pandemic was starting. And it was pretty clear that we were going to have to, everybody, it was all hands on deck, right? I was still living in Buffalo, based out of our headquarters in Washington, and together with others rallied about how do we use maternal and child health funds at this time. So Congress appropriates funds to USAID for maternal and child health, and USAID missions in countries around the world would deploy those funds in the countries where they were located in partnership with governments in order to advance maternal and child health, to reduce maternal mortality, to reduce child mortality, and to improve health systems so that mothers, women, newborns, children get better and better care. It was really important to sustain those services, those essential services, during a time when it felt like practically everything could potentially get diverted to managing COVID.
Right.
Um, but of course, mothers still needed to go and deliver their babies at health facilities, right? Newborns still needed care in the postpartum period and when they got sick. And children would still die of pneumonia and diarrhea unless they were cared for, and malaria. And I worked together with my colleagues to make sure that those resources were going to be well applied during that time.
Right.
So then I became the division chief in early 2021 is when I formally started and started to work alongside many people on the efforts to deliver COVID-19 vaccines. We need to be excellent stewards of these resources. Now, what are the best technical steps USAID can be supporting in order to deliver COVID vaccines to countries around the world? That's also when I got involved in Gavi, the Vaccine Alliance, as part of our partnership with Gavi. And Gavi was part of COVAX, which was this group of organizations, Gavi, UNICEF, WHO, and others that were planning for and helping to deliver vaccines to dozens of countries around the world.
It's so awe-inspiring for so many reasons. And obviously, a lot of that space became very politically charged. And so, if you're comfortable talking a little bit about, what has happened to those efforts now, I think it could be really enlightening for us to sort of understand where those efforts are now, what's happening.
Public health is never a solo contribution, right? It is the work of hundreds of thousands of people, if not millions, around the world.
Sure.
I certainly don't take any one credit for any one thing, and it just doesn't work that way. In terms of the work of USAID and the broader work of USAID, it's a sort of very tender issue for myself, for thousands of my colleagues. So 7 days after the new administration, I was placed on administrative leave. And so right at the end of January it's been a long road. It's been a very painful road because I think that multiple things. One is your bigger question about what have been the implications for US supported health programs. Many have shut down. I'm aware of many places that used to deliver health services for pregnant women, for newborns, for children that are no longer active, for patients with tuberculosis that went offline, where patients were going and actively getting medical treatment, right? So there is an expectation that mortality rose already. There's already a projection that child mortality rose for the first time in 25 years in 2025, and that's likely to continue to increase. The numbers they vary a bit from estimate to estimate because also we're in a dynamic space. Congress has actually appropriated a lot of the funds again in fiscal year 2026. So I think it's really important to see where things go with the administration and how the administration is going to appropriate to allocate those funds and actually get them out the door and for what purposes and how transactional it'll be in terms of the US's foreign policy or other interests versus how much it's intended to do good in terms of a public health standpoint.
Right.
I remain hopeful that there is going to be, I have a lot of colleagues and friends who are still working within the new structures as they are and trying to do their very best to make sure that the resources are allocated in the best ways possible to achieve maximal public health impact. And so my hope really rests with those colleagues and friends of mine who are working incredibly hard in a really demanding environment. So I don't want to lose hope because like I'll always want to be the pragmatic optimist, but I do want to be pragmatic that we are likely to see some increases in mortality. And my hope is that's not for too much longer. You know, one of the greatest joys I've always had in my work is to be out in communities, to talk to mothers, to go to see their homes, their children, to see where they cook, what they experience. I've seen many toilets all around the world.
Yeah.
Um, but really fundamentally, those are the people that I keep in my heart and in my mind in every bit of work now, still.
Yeah. So, as you're talking about like, seeing where people live, where they go to the bathroom, where they do these, that are activities of everyday life. I think about people here in the US, just as a quick aside here, like, for example, parts of West Virginia, that, it's a state in the United States of America where in some communities, they don't have access to safe drinking water, a safe environment. Do you see efforts now that are sort of focused on those regions as well?
Yeah. Here's what I know, and I won't pretend to be an expert in US domestic public health or allocation of resources for the health of our population, which I think is critical. But I'll say a couple of things. One is that early in my time at the University of Buffalo, so I moved here to Buffalo in 2005 and joined the faculty. Hurricane Katrina happened. I reached back to my former supervisor at CDC, my former boss, and I said, should we do something together? Lots of communities are without water, right? And he said, you know what, Pavani, honestly, this is such a reminder. You don't have to leave the country in order to do good public health work.
Right.
It's needed right here. So we did some work, my colleagues and I did some work in Louisiana. Hurricane Katrina happened, and a few weeks later, Hurricane Rita happened. And so we worked in mobile homes that did not have access to clean water. It was back to chlorinating at the point of use. So it's an incredible thing that like we have to be mindful. There is deep inequity in this country. There is deep inequity. Maternal mortality in this country among African American women is exorbitantly high
Right.
and deeply troubling because it's completely resonant of that issue of social justice. Is there any explanation that we can get behind for why African American women are dying at multiple the rates. The second is rural health has been long neglected in this country, but there have been some efforts to like make sure that there are health workers who are maybe they get a certain sort of student loan buyout or certain ways in which they are compensated for practicing in rural areas. But those kinds of programs are less and less well funded now, right? Rural health care is not being prioritized. There are parts of Appalachia that have huge deserts in terms of their health services. That it contributes to preventable deaths, right? There is abundant work to be done right here at home in the US. And we all deserve better and we should demand better.
Right.
We should demand better.
Before we wrap up here, I want to learn a little bit about what you're doing in terms of your coaching experience. And I'd love to hear how you got to that point and what that looks like for you.
Oh, that'd be great. Thank you. I've been reflecting back on how much in residency I love to teach medical students. Um, Mentored junior epidemiologists when I was at CDC. And then, of course, when I was a faculty member at the university, I had my own master's students and doctoral students and loved mentoring them, but also loved supporting them to grow as professionals. And I think in the wake of USAID's dismantling last year, I really stepped back and looked at myself because global health in this country was pretty wrecked. And it was hard to imagine whether I would ever get a global health job again. Um, and that was the reality. And if I wanted a job in global health, it would probably be easier if I left the country. And I didn't want to leave. So I really stepped back and I really looked at all of my identities. Global health practitioner was one of them, but I had loads of others. And I stepped back and I looked at all of my capacities. Who am I? What do I bring to the table? A physician, again, is one part of that. But there was a lot around how much I do love to support other people to grow and be more effective and how gratifying that can be. So I really started to think about what else I could be doing. And my path took, you know, a bit of a road, but I pretty quickly came to wanting to do coaching for leaders, for physicians, for academics. These purpose-driven professions draw people that I really understand because I'm one of them, you're one of them. We get what drives us into these professions. At the same time, many of us are overworked, maybe disillusioned, have a barrage of things that we need to get done without enough time to get them done. And also are saying, like, okay, now I want to grow, but I've never been taught how to grow as a leader. I've been taught how to be a physician or an epidemiologist or whatever my academic field is, but I've never been taught how to lead. And actually, how to lead is a whole variety of behaviors more than it is on specific knowledge base. And so all that work I'd been doing around anthropology and then psychology and work I did as an academic around behavior change research really all comes back now in my work as a leadership coach and a leadership advisor, where I work with academics, I work with public health professionals, and I work with people, even in the corporate world, who are looking to grow as leaders, to figure out what their blockers are, to think about how their stakeholders are perceiving them as leaders, because ultimately a leader isn't just a leader in their own minds and in their own hearts, right? It's like, how do you bring people together towards common purpose and mission and really and achieve that? So I've embarked on leadership coaching and it has been deeply gratifying. I have multiple clients now, one of whom recently I was talking to her sponsors, and one of her sponsors said to me, I don't know what you've been doing, but within a couple of months, it's like night and day. And that is gold, right?
Amazing.
because I don't need to be in the front here, but leading from behind, supporting others to be their most impactful selves is really profoundly gratifying. And so, where I didn't have the one on one patient care after residency, I get to have that one on one experience now as a coach, not as a therapist. I'm not a licensed therapist, but I do leadership coaching, and it's been really an incredible journey.
So the final question that I have for you is, what do you tell your children about leadership? Because I do think that we all have that opportunity at one point or the other to be leaders in our own lives, amongst our colleagues, our friends, our families. What do you tell them about what that looks like?
With privilege comes responsibility. My parents sacrificed a lot for us to come to the US. They took huge risks as middle aged people to bring their relatively young kids to an environment they had no idea about so that we would get educated, so that we would have this big future ahead of us. Their sacrifice was my privilege, and that has brought a big responsibility to give back to the world. Our children live with a lot of privilege. My sincere hope is that they are going to continue to find ways in which they can give back and contribute. And that can take many forms, right? But that we cannot take that privilege for granted and walk on with it.
I love that. You inspire me, and you always have. So I've so enjoyed this time talking to you. Thank you for taking time out of your Sunday to talk to me. And I really, really enjoyed our interview.
You are one of my dearest friends, but also like you've been such a light over a long time. We spent so much time together in medical school. I just wish you the best with this.
Thank you. We'll see how it goes.
Sounds great.
But thanks again. And I love you. You're amazing.
Love you too. Love you too. Thank you.
See ya.